Good afternoon and welcome to the Autumn Sterile Manufacturing series. Today we will be talking about considerations of COVID-19 prevention measures for those working in GMP pharmaceuticals and healthcare facilities. Before we start, just a little bit of housekeeping. During the webinar, we'd like to invite you to ask as many questions as possible. If you can use the questions box on the right-hand side of your screen, and at the end of the webinar, we'll try to answer as many of these as possible. Any we don't get round to, we will answer offline and share them with you, along with all the slides from today and a detailed white paper produced to supplement the webinar. Welcome, as I say, to the start of our autumn webinar series. This series follows on from the webinars Tim presented on behalf of RSSL in the spring. If you missed that series of webinars, they are available to download from the RSSL website, along with the associated white paper. You just need to go to www.rssl.com/events. If you did attend the spring webinar back in May, June and July, and this is your first RSSL webinar, sorry, if you didn't attend and this is your first RSSL webinar, I'd like to welcome you. I'm Annette Russell and I'm the Sterile Manufacturing Lead at RSSL. My role is to help maintain and grow RSSL's partnership with their clients by facilitating communication between the clients and our technical experts in the laboratories, both before, during and after their projects. If after the webinar you'd like to learn more about our offerings here at RSSL, please contact me direct via the email or the telephone number you can see on your screen now. RSSL have been instrumental in helping our clients in several ways in the fight against COVID. RSSL have worked with clients and provided both our expert advice and services to them on a variety of key aspects, from testing of raw materials for drugs destined to ICU units across the country at the height of the pandemic, or to some of the vaccines that are currently in clinical trials around the country. We've investigated some of the syringes that are filled with those key drugs, and we've checked disinfection processes and even the validity of some of the hand sanitizers out there. While it has remained a really busy time here, with plenty of challenges, as I'm sure you're all aware, with social distancing, etc., here we're very proud to have been involved in this critical program of work during this critical time. Those of you who attended our previous webinars may remember that as part of the COVID lockdown, I whiled away my spare time crocheting, including my own COVID virus that you can see here. I had hoped by now that I'd have banished him to the attic, but that sadly isn't to be. Whilst we here at RSSL have been continuing our support to our clients, helping them come to grips with some of the changes that are coming in the new draft Annex 1 proposals, we've also been looking at ways we can expand and improve our service offerings. And I'm pleased to announce that coming in 2021, we will be launching both our identification service via the fast and accurate MALDI-TOF method and mycoplasma to complement our sterility and our biopharma offerings. I'd like to take the time now to introduce you to our guest speaker, Dr. Tim Sandle. I'm sure many of you have heard of Tim and subscribed to his many publications. Dr. Tim Sandle has over 25 years experience of microbiological research and biopharmaceutical processing. Tim is a member of several editorial boards and he has written over 600 book chapters, peer-reviewed papers and technical articles relating to microbiology. Tim works for a pharmaceutical manufacturer in the UK and is a visiting tutor at both the University of Manchester and UCL. I'd like to now hand you over to Dr. Tim Sandle.
So thank you very much for listening in today. And this is a kind of unusual topic for unusual times. So the whole of pharmaceutical and healthcare sector has been massively disruptive during this time of coronavirus, and yet we are one of the core industries for continuing and maintaining public health, whether we're directly involved with doing something directly for coronavirus or supporting the healthcare, pharmaceutical, medical device and aligned sectors in general. So what I'm going to cover in this webinar over the next sort of 40-45 minutes is what is the coronavirus, just to bring everyone up to kind of a level field on this one. How is the virus transmitted? What does the virus mean for personal protective equipment? Which cleaning and disinfectant materials are the best? What are the cleanroom operational risks? And what other factors can we consider to enhance room protection? This is both in relation to the clean room, but also not forgetting the scores of people who support pharmaceutical and healthcare from the office environment or from the warehouse environment and so on, who don't necessarily have the extra protections that clean rooms offer. So just to begin with, let's have a little look at this coronavirus that we're dealing with. So the virus responsible for the disease that is called COVID-19 is a beta coronavirus called SARS-CoV-2, with the SARS standing for severe acute respiratory syndrome. And this is the second SARS virus identified. The first, for those of you with long memories, was back in 2003. And with this second SARS virus, it is 79% similar, based on genotypic analysis, to the original SARS virus. This also has a relationship with another coronavirus of concern called MERS, which was the Middle East respiratory syndrome. And the beta coronavirus, or coronavirus, is an RNA molecule with proteins on its surface. And these proteins, as the picture on the slide illustrates, are crown-shaped or corona-shaped, so hence the name of the virus. And these protein protrusions allow the virus to latch on to a receptor in the lining of the lung. And when the virus latches onto the receptor, it's then able to enter lung cells and hijack the cell machinery in order to make copies of itself. And once it's made tens of thousands of copies, the cell bursts open, and then all these viral particles then move on to infect other cells. And the primary risk to the infected individual is that the cells of the lungs are naturally damaged, and that means the ability for the body to transport oxygen into the bloodstream is severely compromised. Now, in terms of the infectivity, data at the moment suggests that in terms of fatality, it's around between 2 and 3%. However, that's across the general population, as we know from the news, that the greater numbers at risk are older people and those who have underlying health conditions such as diabetes, heart disease, or obesity. It's also known that men are more vulnerable than women. So to put these fatality rates into perspective, for the disease MERS, this was as high as 37%, and for the first SARS virus, this was 10%. However, we shouldn't be complacent about that, and that's for two reasons. One is that the fatality rates of influenza are somewhere between 0.1 and 0.5%, so the current coronavirus of concern is infinitely more serious, and the infectivity rate, the chance of becoming infected, is far, far higher. Now, in terms of transmission of the coronavirus, there are a number of ways that somebody can become infected. So there is direct or indirect contact with an infected item, or mostly a surface where someone touches a surface with viral particles on it. I'll have a look at surfaces in a second, and then touches their mouth, nose or eyes. And infected surfaces are sometimes referred to as fomites. Then there is breathing in droplets, and the primary risk mechanism here are the large droplets that someone produces when they sneeze or cough or talk loudly. And in most cases here, the virus is bound up with one of those droplets. So these droplets tend to be about 100 microns in diameter. And that's quite important for when we move on to look at face masks, is bearing in mind that most of these released droplets are relatively large. And then a related but third mechanism are the virus moving in aerosols. So these are smaller virus containing droplets that might just exist in the air for prolonged periods of time and get blown through by breezes or winds or air changes within clean rooms. And there's some interesting research emerging, which I'll speak about later if we have time, which is about looking at the chances of becoming infected while sitting on a train or on board an aeroplane. And this kind of data is interesting as well, because we can relate that to the office environment as well. Now, looking at surface survival, there's some interesting research available. Some of this relates to the earlier coronavirus, the first SARS, and some of it is topical and relates to the current coronavirus. And what I've done is I've amalgamated together 6 different research papers and had a look at those. So according to this summary of the literature relating to the coronavirus, and particularly the current coronavirus of concern, the recovery times for the virus vary according to surface type and, most interestingly, to temperature. Now, you can see those vulnerabilities, and they're worth bearing in mind for different surfaces that you might have within the office environment or within your particular clean room. Now, there are 2 factors to note, though. The first one is that viral recovery is not necessarily the same as viral viability. So the fact that you can recover traces of the virus doesn't necessarily mean that the virus is still capable of causing infection. However, the fact that you can get recovery and the fact that the half-life is not entirely known, it's prudent to be cautious. The second thing to note is that a lot of these were laboratory studies where surfaces were artificially contaminated using different titers of virus, and those loads ranged between 1,000 and 100 million viral particles. So that is actually, that seems very high, is quite important when we come on to talk about the viral loads of individual droplets. And then you can see this variation with temperature, and that's quite an important factor. So if we take this research overall, then it's demonstrating that the virus can remain recoverable and potentially infectious between 2 hours and 9 days on different materials, based at standard room temperature, which is generally defined as 20 degrees Celsius. Now, at higher temperatures, the virus is associated with shorter persistence. So when we go to 30 degrees Celsius, we see a drop off, and when we get to 40 degrees, then we're getting very low survival rates at all. And the coronavirus appears to be completely inactivated at temperatures of 60 degrees Celsius and higher. Now, there's greater concern at lower temperatures, where studies reveal at 4 degrees Celsius, the ability of the coronavirus to survive on surfaces can increase up to 28 days. And that's doubly important for two factors. One, we're coming into winter, and I'll talk about winter a little bit later on. And secondly, most pharmaceutical facilities have cold storage areas. It also stands, if you consider disinfection in general, that disinfectant contact times are also generally set for 20 degrees Celsius. So if you're going to apply disinfectants in cold rooms, the contact times are going to be considerably longer as well. Now, rolling back to the kind of the high levels of challenges that we use. So at times they were using 100 million viral particles. And that's important because 1 milliliter of sputum, or spit, contains about 100 million viral particles. So all it's really looking as if somebody sneezed violently onto a surface, and that's about the level of viral particles that would be there. Okay, so that's some general background information. So if we're going to consider the risk of pharmaceuticals in general, then the US Food and Drug Administration have produced a very interesting document, which is called Good Manufacturing Practice Considerations for Responding to COVID-19 Infection in Employees in Drug and Biological Products Manufacturing, Guidance for Industry. And within this guidance, there is a clear intention that the FDA expects pharmaceutical manufacturers to have evaluated whether the coronavirus poses a particular and additional contamination risk when viewed against existing manufacturing controls. And this is based around preventing drug contamination and assessing whether the virus adversely impacts upon drug safety or quality. And what it's requiring is that there's a formal risk assessment. Now, it's going to vary across different countries, but in the UK, every company by law is required to have a coronavirus risk assessment, and for that risk assessment to be made available on their website and made available for all employees. And if you take that and then you take up the FDA consideration, then not only is that risk assessment a legal requirement, it also then potentially has a GMP implication as well, and could therefore become a inspectable document. Now, many of the recommendations presented in the guidance document are designed, as I said, to prevent contamination of drugs from infected employees. And they also extend to other good advice like cleaning and disinfecting non-production areas frequently, and about picking the most appropriate disinfectants. It also stands with the risk considerations that there are important steps that the FDA expects, and these include reviewing the adequacy of existing GMP controls, and that relates to materials, components, drug containers, and process materials in relation to potentially infected employees. Manufacturers must also review their clean room process controls. So that's factors like air filtration, positive air pressures, movement of air to ensure that they are functioning correctly and whether they would be enough to address a sick employee. And also the kind of inference of this is that you're going to need to have relatively faster remediation responses if you have a clean room operational problem, because not only have you got the clean room failure impact upon production and clean room impact failure upon general contamination control, but then you've also got potentially infectious person and what is happening to the air that that person's exhaling and so on. And there's also a need to undertake an additional risk assessment where different products are prepared and filled within the same facility. And with this, manufacturers must consider the likelihood of cross-contamination to other drugs. And with the need to protect the product, then the guidance notes that ideally current microbiological controls like closed system processing, such as isolators, should be sufficient to protect medicines, but for non-sterile facilities or other sterile facilities with no barrier technology in place, then you may need to put in additional controls to eliminate or minimize the risk of contamination. And it already stands that for biologics, there should be a good viral control strategy in place. And this would include 1 or 2 or 3 viral inactivation steps. So these go alongside a review to see whether those methods are still effective against the coronavirus, along with the necessity to clean, disinfect and sterilize as part of contamination control measures. Okay, so there's a number of measures that GMP manufacturers need to consider to protect workers and minimize infection. And there's a photograph of myself on the screen wearing a face mask going into a facility when it's shut down. So these general measures are hand washing with soap and water, or alternatively the use of an alcohol-based hand sanitizer. Now, hot soap and water is far more effective because the detergent in the soap attacks the virus directly and in essence rips it apart. The downside with alcohol-based sanitizers is that if you have dirt on your hands and things, then the penetrative ability of the disinfectant is less effective. You need to have regular disinfection of contaminated surfaces, avoid contact with bodily fluids, less likely, but that might be something to bear in mind when there's first aid instances and so on. Simple hygiene measures, and it's important that people isolate themselves if they have symptoms. So these are generally aspects of general good guidance produced by the government, but they need to be put into the pharmaceutical and healthcare context. So it's important that temperature of employees is assessed. So this might be a combination of asking employees to take their temperature before they come to the workplace, and then also having temperature scanning facilities within the workplace. And for areas where there's lots of people, then it's possible to have thermography scanners that can read within a second, and you can have a large number of people going through. And this is important because a rise in temperature leading to fever is probably the most effective early indicator of the onset of COVID-19 symptoms. And obviously anyone with elevated temperature will be screened before they go anywhere near a clean room and be sent home. And in terms of temperature cutoffs, well, the onset of pyrexia is at 37.85 degrees Celsius. But given that most thermometers have a level of inaccuracy, you need to know what that inaccuracy is, and it is advisable to set an alarm point below this value. So for example, if your scanner is plus or minus 1 degree, then you may want to set that cutoff at 36.8 rather than 37.8 to be on the safe side. And there may be the need to have more accurate thermometer assessments as well. And the most accurate type of thermometer is generally the ear thermometer, but that obviously requires particular hygiene controls and isn't as easy for getting lots of people into the workplace at the same time. Okay, so 2 meters social distancing is again something that is recommended by the World Health Organization. I think physical distancing is actually a more accurate term, but social distancing tends to be the one that's commonly used. And this is part of the general measures to prevent the spread of a contagious disease by reducing the number of times that people will come into close contact with each other. Now, this distance is supported by medical evidence. Now, if you take coughing, for example, then there's a couple of interesting research papers that look at the distance travelled by a normal cough under normal conditions in terms of air dispersion. So indoors, that would be 68 centimetres. Interestingly, if someone's wearing a standard surgical face mask, then the distance that the cough can travel, it reduces to 15 centimetres. In comparison, a nasal dispersion, such as the the sneeze, is typically between 50 and 100 centimetres, can go up to 120 centimetres. So by having 2 meters, then you have that degree of protection from typical coughs and sneezes. Now, working in a clean room, the good news is that HEPA filtered air, so HEPA is high efficiency particulate air filters, in combination with faster air exchange rates, gives greater protection compared to non-clean room environments, such as an office. And studies of the first SARS virus indicate that coronaviruses do not pass through the highest grade of HEPA filters. Now, HEPA filters come with different ratings, and within Europe there is a standard EN 1822 that rates HEPA filters, and H14 is the highest class of HEPA filter, and the coronavirus is not thought to pass through that filter into the external air. However, if there are lower grades of HEPA filters, then these can potentially lead to contamination going through. So this leaves other routes as well. So one being people, so continuing to practice good gowning. And the second is with having fast air exchange rates, which are designed to remove particles from clean rooms. And data also suggests that there's lower transmission of viral infections under conditions where there's 20 or more air changes per hour. There's going to be variables in terms of room dimensions. And another area of concern is how items are coming into the clean room, and we come on to that when we look at disinfectants. There are some studies as well that say that HEPA filters can be enhanced through ionization. And this might be something to consider where HEPA filters below H14 class are being used. So this is where ionizers can be fitted to treat the air being taken in prior to the pre-filter and then before passing through the HEPA filter. So these methods use a combination of ionizing processes and the electrostatic attraction of particles, and they're particularly effective for particles greater than 0.003 microns, which includes not only viruses but also bacteria and fungi. There's also some research going on into ultraviolet light, specifically UVC light, which is ultraviolet light at 260 to 285 nanometers. So there is research looking at UVC for surface decontamination against coronavirus, and also whether it's something potentially used to treat air as it's passing through into the filter. Now, with both of these, the key issue is contact time. And I got an email the other day, somebody trying to sell a little box that you could put a mobile phone into, and it gets treated with UV light, and they said it would take about 15 seconds. Well, that's clearly nonsense. You do need considerable time of UV exposure in order to ensure that you are destroying millions of viral particles. So it's being looked at, but I don't think there is a great UVC solution at the moment. Now, looping back to temperature, the chance of viral infection has been shown to be reduced where there is a higher temperature and lower relative humidity. And this rests on the virus most often being within a droplet. And that makes sense because it's what people cough or they sneeze. So at higher temperatures, this dries out the droplet faster compared with conditions where the air is cooler. And a faster air drying time reduces the possibility of viral survival. However, where there's lower humidity, it adversely affects the coronavirus by causing interactions with the polar membrane on the virus and causes the virus to be inactivated. And the reverse is that in moist environments, then it creates better conditions for the virus to survive. So one tip for offices is to increase air exchange rates, to increase the temperature, and to lower the humidity. And these are some factors that may help with coronavirus controls. And this has all been measured, these different conditions. So with the different research papers that have been produced, is that virologists have gone out with special biosamplers and assessed viral rates and the viability of different viruses. It is possible to have a look at clean rooms and to work out how well they're working using computational fluid dynamics, and the picture on the screen is an indicator of such a study around a clean room with some computer vaccine. But you can gain information about the potential air patterns within the room, which are affected by heat and by mass transfer. So this is generally anyway a good practice for contamination control within clean rooms, to knowing how the air circulates and where it is relative to the product. But also these kind of patterns also show why masks matter, which we'll come on to in a minute. Linking up the temperature humidity as well is that obviously in the northern hemisphere we're approaching winter, and here the combinations of lower temperatures and high wind speeds will increase the potential for virus transmission. So it's probably an indicator that personnel will be under a slightly greater risk this time of year. Wearing cleanroom gloves is one method to help minimise viral transmission within the clean room. Now, obviously, in aseptic facilities, people are wearing gloves all the time, but in some other lower grade clean rooms, that may not be a requirement. So wearing gloves at all times can also help minimise viral transmission. Now, the degree of protection depends upon the type of glove, the particular glove composition, the glove manufacturer, the glove design, and the degree of mechanical manipulation that is practiced. And these factors can have considerable influence upon glove performance in terms of leakage and viral penetration. Studies also show that latex gloves are generally superior to vinyl gloves in terms of providing barriers to leakage and viral penetration. However, there are also a number of people who have latex allergies, so there's always going to be a compromise there. And the frequent application of glove disinfectant is also very important, and we'll come on to disinfectants in a minute. Now, with face masks, then within the pharmaceutical and healthcare sector, then the surgical mask is the most common type of mask worn. And within Europe, the standard for the surgical face mask is EN 14683, which was last updated in 2019. And it describes three classes of masks called types 1 to 3. And these are based on their particle filter efficiency ranges, which range to filtering out between 95 and 98% of particles of 3 microns or greater. And the equivalent standard in the US is the ASTM F2100 standard. And generally, people in clean rooms would wear the type 2 or type 3 masks. There's obviously a lot of talk about respiratory masks as well, and these are not normally worn in clean rooms unless people are handling quite noxious substances, and generally they're not suitable for aseptic processing areas. But the European standard for respiratory masks is EN 149, which was last updated in 2001, and here the masks are classified as filtering face pieces, FFP1 to FFP3, and these are equivalent to the US NOSH standards, which are N95, N99, and N100, and these filter out particles of 0.3 microns or greater. Now, although surgical face masks will partially reduce the viral transmission from the wearer to another person, it should be borne in mind that face masks don't offer as great a protection to the wearer should someone else be infected with the virus. That's because masks generally are filtering in one direction, which needs to happen to allow the wearer to breathe. So putting a mask on an infected person is 300 times more effective than putting on a mask of the potential receiver of any infectious droplets. But as we don't know who is infected and who isn't, then wearing masks, particularly where 2 meters can't be practiced, is a sensible thing to do. It also stands that surgical face masks work better with larger particles, and then you might be thinking, well, the virus is very, very small. But if you go back to the point I was saying near the beginning, is that nearly all of the viral particles that are exhaled are in the form of droplets, and these tend to be between 10 and 100 microns. So theoretically, the vast majority will be captured by the filtration efficiency of the face mask itself. If you're considering face masks for personal use, then it is important that most face masks are only designed to be worn once, and that's why they're called disposable masks, and that the efficiency of any mask will decrease over time, and that decrease is accelerated when the mask becomes wet or if it becomes damaged. So within a typical cleanroom environment, for example, a mask might be worn for 4 hours maximum. So it doesn't make a lot of sense to be wearing the same mask, have the same mask for outside for many months on end without at least attempting to treat that mask in some way. So masks are important, but social distancing and disinfecting services and washing hands are all equally as important, if not more important. Another risk with face masks is that if the masks are not fitted securely, then there's a phenomena called deflection, which is where exhaled air and droplets are directed through the fine gap between the mask and the skin, leading to outward leakage of what's called the face seal perimeter. There was a study done recently in the US at the US Department of Energy, Center for Nanoscale Materials, and here they looked at even just like a 2 or 3% ill fitting of the mask can release around 25% of the viral particles. And this also affirmed that most manufactured masks only last for a finite period, and then there is a loss of integrity. Cleanroom suits are generally okay because they are packaged in clean conditions. The laundry process will eliminate any viral residues, whether suits are first worn suits or relaundered suits, and particularly if they're going into aseptic areas, the suits will be sterilised. But that's provided that cleanroom suits are either single use or in non-sterile facilities or lower grade clean rooms, they are worn only for 1 day at a time, and then are appropriately disposed of in using bins that don't get too full, that people aren't then touching a suit worn by somebody else. Goggles are worn in aseptic facilities, and these can also help because a big route of infection is via the eyes as well, so that offers additional cover as well. So as it stands in general, the safest place to be is probably within an aseptic filling area where all parts of the skin, eyes, and mouth are covered up, and there's high air change rates, and everyone's wearing a brand new piece of sterilised personal protective clothing, and then the risk increases through other clean rooms and then into offices and things. Now, cleaning and disinfection measures are important. Cleaning is always an important pre-step prior to surface disinfection because most disinfectants have poor penetrative ability to going through, so there's a protein residue or some dust or something like And it's also important to regularly clean and disinfect, looping back to the fact that the virus can survive on surfaces for long periods of time. Now, as to the best disinfectants, literature indicates that alcohol is optimal, and that alcohol of the right concentration can inactivate the coronavirus within about 30 seconds. The best alcohols to use are ethanol, typically a concentration to 61 to 71%, and isopropyl alcohol at a concentration of around 70%. What is not effective is methanol, and I think the US FDA have issued over 100 warnings about fake hand sanitizer products getting into the market, and most of these contain methanol rather than ethanol or IPA. So not only is methanol not effective against the coronavirus, it's also highly toxic as well. Second to alcohol is hydrogen peroxide, and here studies show that concentrations of 0.5% or above are effective in around 1 minute against the coronavirus. Two other points about disinfectants is that they're best applied by spraying and wiping rather than just spraying, because you need to apply pressure at the same time. And with hand sanitizer products, if you come across products that are perfumed or have an aroma, then they're probably not any good, because the only additive that the World Health Organization recommends is some form of moisturizer to stop the hands drying, but they typically shouldn't be perfumed. So outside of clean rooms, it's very important that non-GMP areas are regularly disinfected. And this includes keyboards and monitors and telephones, and that if you're fortunate to have your own desk, then do that once a day. And if you're hot desking, that it's done between every changeover of a member of staff. Another area of concern is with toilets, and it might be a slightly unsavory subject, but researchers have found that fecal-derived aerosols will also contain the coronavirus. So good hygiene practices around toilets, such as particularly closing the lid of the toilet, will help minimize the spread of the coronavirus. It's also good practice to have a coronavirus response kit within the workplace, so that should anyone become ill at work and they go home, that the area they were in can be looked after very quickly, including things like barrier tapes, pre-printed signages, a map of the area, because the person responding might be unfamiliar, particularly in a complex pharmaceutical facility, masks and gloves and suits for the person to wear, and the appropriate cleaning materials and so on. So if you have this kit ready made up, it makes dealing with the issue quicker and means that you're protecting the products faster. Another factor that we have to consider within the pharmaceutical healthcare is business travel. Now, we might try and minimize that and avoid unnecessary visits by sales reps and things, but there's always going to be things like factory acceptance testing, or to go and review contract test laboratories, for example. So here it's important that managers review the trips, see if they can be replaced with video conferencing, and coming up with an appropriate risk assessment and issuing employees with the appropriate materials that they need, particularly for longer term business trips. So this would be things like face masks, plans of the journeys, mobile phones, etc., etc. Now, this might seem over the top, but there's, looping back to something I said at the beginning as well, there's two really interesting studies, one on railways and one on airplanes, and they've both shown that if you're sitting in a railway carriage or you're sitting on an airplane and somebody has coronavirus and they're not wearing a mask, then typically most of the people within the standard aircraft cabin or within the standard train carriage face a very strong risk of becoming infected within an hour. So it takes about an hour to build up enough viral particles in the airstream. The biggest risk is sitting side by side with somebody. The secondary risk is sitting opposite to someone, and the safest position is actually sitting back to back. but there are considerable concerns. There's also similar concerns with carpooling as well. So there's also various measures to take into account. It's also important that employees behave sensibly as well. So nobody likes to grass up or inform on a fellow employee, but for the good of everyone, really people should not break social distancing. People shouldn't try and cram into locker rooms and changing areas, which often people become impatient getting into. We should always have good hygiene standards in restrooms. People shouldn't spit, they shouldn't spit anyway. Shouldn't leave waste materials behind. If people cough or sneeze, they should cover that as they do so. Face masks shouldn't end up in laboratory coats or clean room operated bins or discarded on the floor. They should go to be treated as infectious waste. And for those of you who are leaders or managers, then it's very important to lead by example. Okay, so that is the end of the presentation. Just as a recap, we've looked at what the coronavirus is and how it's transmitted. We've looked at appropriate disinfectants to use. We've looked at the different levels of PPE and what they can deliver. And we looked at the protective environment that clean rooms create. And we also have some advice around temperature and humidity, and we might be able to modify things in offices. And we always have to be mindful that how long the virus might be present on a surface for. So that wraps up the main presentation. I'm happy to move on to questions and answers.
Thank you, Tim. That was a very comprehensive covering of the considerations we need to do to prevent COVID-19 spread in GMP pharmaceutical facilities and healthcare facilities. We have had a few questions come in, a couple around face masks. The first one from Sarah says, what do you think of homemade masks, such as those made of cotton?
Yeah, that's an interesting subject. So obviously not suitable for the workplace. Employers should issue surgical grade masks to all their employees, whether they're in clean rooms or within offices. If people want to make their own masks, then strangely, yes, cotton is the best material. Whatever homemade mask is made, it needs to be double layered. But we do have to bear in mind that they're always going to be less effective. So if you take the surgical face mask, let's say for the sake of argument, you rate that as 100%. One study I was reading would put double layer of cotton at 67 to the face mask. And then you can go down through a range of different materials. Interestingly, wearing a balaclava actually produced greater chance of passing out more coronavirus and not wearing any kind of mask at all. So we do have to bear in mind that these there's limitations. It's also important to regularly either change the mask or to attempt a disinfection method. Probably the best disinfection method is either to steam, to place the mask over boiling water, let steam rise up, or to put it into a microwave. But you've got to bear in mind that all these kind of practices will eventually affect the integrity of the mask itself.
Okay, thank you. That's quite interesting. I'll think about microwaving my own face mask now. We have a question from Mark also on face protection, and he asks about the face screens that we see and whether they are adequate PPE or do they need to wear a mask too?
Face screens, I don't think are terribly great. Obviously, they allow air to circulate, and the face screens are, the purpose of them. They're worn by nurses and doctors to stop other people's bodily fluids splashing them in the face. They're not really designed to be substitutes for masks, so I'm personally not keen on them. The mask itself is generally better. And again, go back to good quality masks. Don't try not to go for some of the masks that are being portrayed as fashion items. So if you see a mask made by Kim Kardashian, it's probably worth going for a proper surgical mask or something.
Right. Mark also asks, would we need to quarantine drugs for a period of time if an employee who has handled them has been confirmed positive for COVID? Do you know?
That's a difficult question because it depends on what type of drug it is. I mean, if it's a biologic, then it should have an established viral inactivation step anyway. So the key viral inactivation steps for biologics are either nanofiltration, solvent detergent treatment, or heat. So they should be generally safe. With other types of drugs, really, it just depends. It depends on what the risk factor is. So yeah, it's difficult to answer. Possibly, but you'd have to run a risk assessment, and if there were concerns, you'd probably have to talk to the regulator.
Okay. I had a question in from Hannah saying, do you think hot soap and water or hand sanitizer is the best method of decontaminating hands?
Strangely, with this, with viruses and with coronavirus particularly, hot soap and water is actually superior to a hand sanitizer because the heat's effective, and the use of a detergent is really good at destroying the virus. And I think the point I said during the presentation was that sanitizers are still very effective, but often if you're coming in from outside and your hands are a bit dirty, squirting the sanitizer on may not, if you've got bits of dirt on there, it may not be quite as effective as the soap and water in this instance.
And still on hands.
Oh, sorry, Annette.
Sorry.
Also, if you're out and about, let's say you're going out shopping and you're worried about somewhere not having any hand sanitizer and things like that. Quite a good trick is actually to get like a water bottle and to put some water and washing up liquid in it. If you take that out and you go somewhere there isn't any hand sanitizer and put a bit of that into your hands, that's just as effective. So there's a little tip there.
Okay. Still a little bit on the hand sanitizer side of things. Orla has asked, should a different disinfectant be used for gloves rather than for hands and surfaces?
Yes, generally that's the case. So the disinfectants used for hands should really contain some form of moisturizer like glycerin. And it's been, because you don't want hands to dry out, and as we're all sanitizing our hands far more often, then obviously you don't want to get cases of dermatitis. So generally for bare skin, it's better to use ethanol or in a denatured form. So what sometimes used to be called IMS or industrial methylated spirit, denatured ethanol with some glycerin in it. That is better for the hands as long as the concentration is above 61%. For gloved hands, then something like 70% isopropyl. That means have any moisturizers in there, tends to work very well, and that tends to be used because it dries out fairly quickly, so the operator's not standing there with their gloves for 10 minutes waiting for their hands to dry so they can move on. So that's why generally as a rule it tends to break off that it's denatured ethanol for bare skin, IPA for gloved hands.
Okay, I've got a couple more questions that we can squeeze in before our time's up. I've got one from Mona. She's asked, what is the effect of contamination on injectable vaccines by coronavirus? I don't know if you can answer that one.
It's kind of, yeah, the trouble is it's a depends.
Yeah.
Yeah. I mean, obviously, I think if you're making vaccines, again, that's a product where you should have a viral exclusion system in place anyway. So really, you're wanting to exclude all viruses from the process, including coronavirus. You don't really want to be administering a vaccine where you've got viral contamination in it, so that you'd have a proven viral inactivation step.
Okay, and then I've got one from back to face masks, strangely enough, from Yale. It has asked, what is the recommendation regarding mask exchange during the working shift? As we know, the bioburden of the mask is high and potentially can contribute to clean room bioburden.
Okay, I'm not sure what by mask exchange, is that changing masks or?
I would assume so.
Generally, face masks have about a 4-hour use. This is the standard masks in the clean room. It can be up to 6 hours, but then you're often really having employees working for longer because they need to go for toilet breaks and lunch breaks and various things like that. I did look at some data from years ago in relation to bioburden, where it was a whole series of studies on contact plates taken on the face of on the outside of the face mask. So you do start seeing contamination build up, and that's a natural product of the mask becoming increasingly moist from the breath and things like that. So if I'm answering the question correctly, I'd plump for 4 hours to change the mask.
Okay, and we've just to finish up with our questions. I've got one from James who says, how would you control staff moving through changing rooms?
It should be a controlled process. So within clean room changing rooms, there should be limitations on personnel numbers anyway, because you're going to get more people you've got in there, the more particle build up there is. But with the coronavirus restrictions, it seems to be that if people are spending 5 minutes or more without social distancing, then the chance of infection increases. And obviously they're stationary, we've got this thing about leading up to the hour. So I'd minimise the numbers, ideally have one-way process, but if people are passing each other short term, then the risks are relatively low.
Okay, well, that's all we've got time for in terms of our questions. Thank you again, Tim, for that overview. So I'd like to thank you all for attending this webinar. I hope you found it useful and we appreciate the questions you've asked. We seem to have answered most of the questions that came in during the webinar, but if there's anybody that's still typing one, we'll pick it up in the next few minutes before the webinar ends, or if you've got any questions, you can always email me at my email address. I'd like to take this opportunity to remind you that this is the first in our 3-part autumn series that Tim's kindly going to cover for us. If you want to register for the next webinar, which is on the 18th of May, it's called Best Practices for Cleaning and Disinfectant. Just pop along to our website, www.rssl.com, go to our events page and you can register there. On behalf of the sterile manufacturing team here at RSSL, I'd like to thank Tim again for delivering such an informative webinar to us all. I'd like to thank you all out there for listening. Please do not hesitate to contact me if you have any questions or if you need any support with any of your projects. Thanks for your time and hopefully we'll see you on the next webinar in November.